Hello again, and welcome to the final video on ionizing radiation and physics of fluoroscopy for the FFPMRCA. In this talk, we're going to talk about clinical aspect, safety aspects, and this lends out quite well to both sections of the exam. And indeed, many aspects we're going to discuss in this video have been asked multiple times, whether it's in the MCQ part or the SOE part. And so, a good word to throw out there in your SOE exam when you're talking about safety is the use of a linear no threshold model. Quite simply, what that means is that there is no safe dose of radiation. So, you can't say that below this dose there won't be any damaging effect, and that's what it simply means. And it basically has three principles. One is no safe dose, which I've just mentioned. The second is linearity, which means that if I double the dose of radiation, I get double the effects. If I half the dose of radiation, I get half the effects, or a 50% reduction of dangers of radiation. And the final one is the aspect that is cumulative. So basically, repeated exposure accumulates the danger and the injury to cells. So you don't have an X-ray and then it resets to zero when you have another X-ray a week down the line. It's a cumulative effect. And before you start talking about how to safely manage radiation or reduce exposure occupationally, it is important to be aware, and it is also something that has been asked. What are the dangers of ionizing radiation? How can it affect the body? And if you recall from the previous presentation, we've had this picture where basically we stratify the risk of radiation depending on the sensitivity of the tissues. And if you also remember, how sensitive tissues are to radiation is a factor of how actively dividing they are. And you can actually use this to classify the different dangers based on systems. So if, for example, you take the hematopoietic system, so one of the effects you can get is then bone marrow failures, pancytopenias, um, lymphatic tissues. So you can get cancers relating to the bone marrow and the lymphatic system. Reproductive system, so naturally the clinical symptoms might present in decreased fertility or infertility. Gastrointestinal system, that can present in nausea, vomiting, GI symptoms, GI cancers, epidermis and eyes. So you might get skin damage, skin epilation, you might get cataracts. Lung, kidneys, liver, and thyroid glands. So that again could be cancers of these systems, or it could be things like fibrosis, interstitial lung disease, liver disease, and liver failure. And then finally, within the nerves, you can get neuropathic pain and problems within nerve conduction and transmission. Another way of classifying these symptoms is by their effect, whether it's deterministic or stochastic. So if you remember from the previous talk, deterministic D, so it relates to the dose, starts with the D, so which means that the increased dose of radiation means that you will get more of a severe injury. And these effects will be things like skin epilation or skin burns, cataracts, infertility or sterility, and organ dysfunction. Whereas the stochastic symptoms are the ones where repeated exposure increases the probability of getting the symptom or the injury, but has no relation whatsoever to the severity. So things like cancers or genetic mutations, if you have repeated exposures of ionizing radiation, you have a higher probability of getting a cancer. That it has no bearing to the severity, whether the cancer is going to be something that is localized or metastasizes. That is not related to the dose of radiation itself. You will have, when you read in different papers, that some papers will look at cataracts, which is mentioned here as a deterministic effect, and they will classify it as a stochastic effect. And you will also see some other papers which will mention that fetal defects are actually a deterministic effect rather than a stochastic. Um, but I mean, you don't need to worry about that detail. I'd stick just with the general principle and list a few of the symptoms if asked about it in the exam. So, if you get asked about the factors affecting radiation exposure in the interventional suite, I think this picture is actually quite a good summary where you can classify the factors. So, you've got patient factors, you've got technical factors, which relates to the device you're using and how you're using it. You've got then an operator who is luckily enough standing far away outside of the screen. So, you've got operator factors, and then you have got procedure factors, the procedure you're doing itself. How can it affect the radiation? Okay, so we'll start off with the patient factors, and the main one actually here is the BMI. If you have a patient with a higher BMI, they need a higher dose of radiation, uh, just so that you can get good penetration through the tissues in order to get a good image. And that naturally means a total higher dose of radiation to yourself and the patient, but also more scatter of the patient, and so a higher risk for yourself. From a procedural point of view, the complexity of the procedure is important. If you're doing a lumbar medial branch block, you're only taking a few still images from a fluoroscopy point of view. Whereas if you're doing a cervical stim, for example, that's going to be a much longer procedure. You're probably going to screen, and so that means a higher dose of radiation. From the technical side of things, the source of radiation is important. Are you using a C arm, which is the least amount of radiation? If you're using an O arm, which completely surrounds the patient, that's a higher amount of radiation. If you're using a CT, so CT guided procedures, that's even a higher dose of radiation. The mode of radiation itself, which means are you taking still images or are you screening? And if you're screening, are you doing a continuous screen or are you pulsing the images in a screen? So actually, what's the frames per second when screening? And that's actually a good important factor to potentially try and work on practically. So you can try and reduce the number of frames per second so that even when you're screening, you're not actually continuously screening all of the time. The position of the C arm, and I'll talk about that in the next slide. And then you have radiographer factors. And that just means what your radiographer is doing. So your radiographer will, at certain points, increase or decrease the exposure. You will ask the radiographer to get in a certain position, so craniocaudally or oblique, to try and get the best image. And if you've got a good radiographer, they can try and get you the best image in the quickest way possible, so that you're reducing the amount of images that you have to take. So that does factor into the process, and a lot of the good radiographers will automatically collimate, will think about the exposure to yourself and to other members in the room and chat to you accordingly if they think we could modify something to reduce that exposure. Finally, you've got the operator factors, which is distance and shielding. And shielding here is self-explanatory. It refers to using of lead material. So whether these are lead goggles, lead thyroid shields, lead aprons, making sure that they are all adequate, that they are covering the area correctly, they're used by all members of staff. And then the distance is something I'll talk about in one of the next slides also. So when we talk about the position of the C-arm and how that affects the exposure, we're talking about where the X-ray source is. So on one side here of the C-arm, you've got the X-ray source at the bottom, and then you've got the image intensifier at the top. And what happens here is the X-rays are going to go from the bottom, go to the patient. Some of it will be absorbed by the patient, and then the rest of it will be scattered in various directions. And depending on where the X-ray source is, so let's say you've got your X-ray source at the top and the image intensifier at the bottom. Essentially, what's going to happen is that the X-rays are going to go through the patient, and most of the scatter is going to go in this area. So basically, if you're standing here or here, you are going to get a lot of that scatter. Whereas on the other hand, if you put the X-ray source at the bottom and the image intensifier at the top, actually most of that scatter is going to go below you onto the floor, so you get less exposure. So always remember, have your X-ray source at the bottom rather than at the top. And so using the same principle, we can apply that to oblique and lateral C-arm movements. So actually, if you start in the AP position, and you've got the X-ray source at the bottom here, what tends to happen is most of the scatter is going most of the X-rays are going to hit the patient and then scatter off at the bottom to the floor. As you start obliquing away from you, basically you're standing on this side and you're obliquing the C-arm away from you. The X-ray source is becoming closer and closer to you till you reach a full lateral. And so that is what is being shown here in this image. So in a lateral image of the C-arm, you are standing right here, just next to the X-ray source. And what that means is that the X-ray beam is going to go through the patient and scatter mainly back to you. So a lateral X-ray will have a higher risk to you than one in AP. The other thing to consider also is when you're doing a lateral X-ray, there is much more tissue to go through from the side than there is from the back. So the C-arm will automatically adjust for that and increase the amount of radiation. So there's two factors why a lateral C-arm position is a higher dose of radiation to yourself. And so if you think of it, if you're an AP, that's probably the best way to reduce the amount of radiation. As you start obliquing away from you, you start increasing the dose of radiation coming to you through scatter, and that keeps on increasing till you're in a full lateral position and the X-ray source is very near to you. And likewise, if we do it the other way around, so if you are obliquing the C-arm towards you, what tends to happen is that the X-ray source right at the bottom here is going to start moving away from you, so reducing the amount of radiation you're getting uh, till it comes back to a fully lateral position on the other side, where essentially you will receive the lowest amount of scatter. However, there is still an increased dose of radiation coming just by the fact that you're doing a lateral X-ray. So if you think about it, being in an AP position with the X-ray source at the bottom is probably the best from a radiation exposure point of view. And the other factor I've mentioned earlier when it comes to radiation exposure is distance. And distance is the most important factor when it comes to radiation exposure. And that's because radiation exposure is inversely proportional to the square of the distance from the source. So if you double your distance from the X-ray source, that reduces your radiation exposure to 1/4. And actually, this is a very good image to look at because you can see here, even as you're standing, the exposure that you're getting or your hands are getting can be much higher than what your back is getting. And so one thing to have in mind when you're doing x-rays is to try and keep your hands away from the source, and if possible, if you want to take still images, try and walk far from the x-ray source, take the image, and then come back closer to then carry on the procedure. All right, so another spin-off of the things we talked about is you could get asked in the SOE on measures to reduce radiation risk, and that's just basically looking at the factors that affect radiation and then classifying those into measures to reduce that risk. So you can start by having institutional measures, so basically regulations for management of ionizing radiation exposure, whether that's at a governmental level, so things like IRR 99 or IRMR, or at a local level, like having policies and having a lead responsible person to manage radiation risk, and provision of resources, both for monitoring and for safety. So having regular servicing of the lead equipment, making sure that they are available to the people being exposed to ionizing radiation, and so on. And then you have physician factors. These are distance, which is the most important, time, shielding, and monitoring. So the more distance you have from the X-ray source, the better. The less time you have producing ionizing radiation through the C-arm, the better. Shielding, which we've spoken about, and then monitoring, which is in the form of dosimeters. And you can have two types of dosimeters. You have dosimeters which can be worn under the lead gown. So these are the ones that you'll classically have at the chest level, being under the lead apron. And then you have dosimeters that are used for exposure of the eyes, or rings that will be worn by radiologists, for example, that will monitor exposure outside the gown, or exposure for cataracts. And finally, I have grouped these as radiographer slash pain physician factors because I think both of them share the responsibility. And one of them is the energy and quantity. So these are settings within the C-arm itself. And most modern fluoroscopy will have something called an automatic dose rate control, where it will automatically adjust the exposure of each image to try and automatically get the best image for the least amount of radiation, but it is something that can be manually overridden. And a good example of that is when you're putting a stim, you might be trying to look at where the lead is in relation to the vertebrae and the level, but you're not that interested in the intricate details of the spine itself. So you might allow for a slightly reduced image quality as long as you can see where the levels are and where the electrode is. The other is collimation. Always make sure to collimate. That basically reduces the amount of scatter. And then finally, the image intensifier, which relates to the position of the image intensifier and the X-ray source in relation to the operator themselves. Okay, so let's do some MCQs. The first one says, of the following, which measure provides the greatest reduction on occupational radiation dose to the operator? I'll give you a few seconds, pause the video, think about it. This is a single best answer, so only one answer is correct. All right, so this one is quite straightforward. Obviously, it will be increasing the distance from the radiation source. As I've mentioned earlier, radiation exposure is inversely proportional to the square of the distance from the source. So if you double your distance, you reduce your radiation exposure by 1/4. All right, I've got the second question here. Have a look at the question and the answers. This is a multiple true-false question. Pause the video, have a think about it, and then I'll bring the answers in a moment. So this is also a relatively straightforward question, and going through the answers, choice A, collimation, of course, will reduce the area if tissue being irradiated because you're basically reducing the divergent beams, so less photons are going to go to the patient, and that means less scatter. B is false. Continuous fluoroscopy will deliver a higher dose compared to pulse fluoroscopy. For choice C, positioning the image intensifier close to the patient reduces the dose required to produce an adequate image. That is true, and that's because we've got basically the patient here, you've got a bit of an air gap and then the image intensifier. And so if you reduce this air gap, what tends to happen is that basically the image intensifier will receive a higher percentage of the X-ray beam. And because it's receiving a higher percentage, then that can reduce the exposure. The system itself doesn't need as much X-ray photons in order to produce a good image. So that answer is going to be true. For choice D, digital magnification. So the word here is digital. Reduces the dose delivered to the patient. Compared to standard field of view imaging, that is actually false. And that's because digital magnification happens after the image has been collected by the image intensifier. So it's basically something that is done digitally through the computer and thus has no effect whatsoever on the dose. It doesn't increase it, it doesn't reduce it. And finally, choice E, standing on the same side as the X-ray tube increases the exposure to scatter radiation. That is correct. If you're closer to the X-ray source, you get more scatter. And so that's the end of this series on physics of fluoroscopy and ionizing radiation. I hope you found it helpful. If you did, please subscribe to the channel. Please drop a comment on what topic you'd like for me to talk on next, and I'll see you in the next time.